Good morning. Here today we are explaining the anterior cerebral circulation occlusion. It's me, Luca Roncari, Eduardo Jimenez, Lorenzo Giuntoli, Nicola Cabiddu, and Gideon Lawrence. Here we can see the learning outcomes. Differentiation outcomes among different branches of internal carotid artery, sign and symptom of 3 different types of anterior choroidal artery and occlusion, understanding which area are affecting the anterior cerebral artery occlusion and its consequence, give the diagnostic measures for an anterior cerebral artery occlusion, understand the epidemiology, sign, symptom, and prognosis of the middle cerebral artery, identify the clinical implication of middle cerebral artery branches occlusion, recognizing the difficulty in finding internal carotid artery occlusions, understanding the sign and symptom of the internal carotid artery. Okay, so first I have an overview. The brain is the most energy-intensive organ of the human body. Even if it is 2% of the total body mass, it uses 50% of the body glucose, so it is one of the most perfused organs. This perfusion is provided by 2 major sources of arterial blood divided in anterior and posterior circulation. Anterior circulation is provided by internal carotid artery and its main branches, which are anterior cerebral arteries, middle cerebral arteries, anterior choroidal arteries. They supply 80% of the total cerebral blood flow to large portion of the forebrain, including frontal, temporal, and parietal lobes, and parts of the diencephalon and internal capsule. Posterior circulation, also known as vertebrobasilar, is provided by the vertebral arteries. It accounts to 20% of total cerebral blood flow, direct to the posterior portion of the brain that includes the occipital lobe, most of the anterior and posterior portion of the brainstem, and all of the cerebellum. Both circulatory divisions provide major branches to the diencephalic and telencephalic regions of the brain thanks to the circle of Willis, the joining area of the anterior and posterior circulation. Perturbation of any portion of this blood supply promotes the development of cerebrovascular disease. The most common is stroke. Stroke occurs when there's a loss of blood flow, nutrients, and oxygen to a region of the brain. Is an acute neurologic injury causing neuronal damage and neurological deficits. It can be classified into ischemic stroke and hemorrhagic stroke, the latter of which includes intracerebral hemorrhage and subarachnoid hemorrhage. Ischemic stroke is defined as the infarction of the brain, spinal cord, or retina, and presents 71% of all strokes globally. Stroke is a leading cause of death and disability worldwide. Epidemiology, strokes include ischemic stroke and hemorrhagic stroke, affect 14.7 million people globally per year, and is the second leading cause of death with 5.5 million deaths per year. An estimated 1 in 4 adults will experience a stroke in their lifetime, and there are more than 80 million survivors of stroke globally. Risk factor we can divide in non-modifiable and modifiable risk. The non-modifiable include age, sex, and genetic factors. The modifiable are hypertension, low level of regular physical activity, diet, high waist to hip ratio, psychosocial stress and depression, smoking, cardiac causes such as the atrial fibrillation and previous myocardial infarction, high alcohol consumption, and diabetes mellitus. Symptoms can include hemiparesis, hemianesthesia, numbness on one side of the body, aphasia, language disorders, homonymous hemianopia, loss of the same half of the visual field on each eye, and hemispatial inattention, reduced awareness of stimuli on one side of the space. Large ischemic stroke can generate systemic effects, hypertension, arrhythmias, bradycardia, and pulmonary exudates. Go back on one slide, please. Brain imaging used to diagnose ischemic stroke are non-constant CT, CT perfusion, CT angiography, digital subtraction angiography, and MRI. The clinical presentation of stroke involved the sudden onset of a focal clinical deficit referable to a specific site in the central nervous system. The clinical manifestation of an ischemic event depends entirely on its placement within the vasculature. The deficit observed in the patient is a direct consequence of which or what portion of the brain is affected by infarction. The broadest distinction to appreciate in this connection is between the anterior and posterior cerebral circulation. Now it's time for the next presenter.
One slide back, please. No, back. Thank you. Okay, one of the most critical regions in the brain is supplied by the anterior choroidal artery, a small tiny artery that can be involved in many diseases, including aneurysm, brain infarct, NND, brain tumor, and traumatic cerebral hemorrhage. The anterior choroidal artery supplies structures that are crucial for motor and sensory function, as the lateral cingulate body, temporal bone, posterior limb of internal capsule, optic tract, and medial pallidum. It can be complete, incomplete, or bilateral. During its complete form, anterior choroidal artery infarction usually presents hemiplegia, caused by the involvement of the pyramidal tract in the posterior limb of the internal capsule. And sensory loss, like light touch or pinprick, due to the involvement of the ventral posterolateral nucleus of the thalamus or of the thalamocortical fibers, is less frequent. And it's also possible an hemideficit of the visual field. The complete anterior choroidal artery stroke are usually associated with cardioembolic sources and carotid stenosis. Next slide, please. Yeah, thank you. Obviously, different pathophysiologic mechanism can produce different ischemic stroke reported with the anterior choroidal artery syndrome. Most strokes are typically due to type 2 diabetes mellitus, hypertension, and hyperlipidemia. The triad of symptoms that is usually present in anterior choroidal artery occlusion, hemiplegia, hemianaesthesia, and contralateral myopia is rare to see because of the anastomosis from the middle and the posterior cerebral and the posterior communicating arteries. Another reported cause of anterior choroidal artery infarct includes large vessels, arteriosclerosis with artery-to-artery embolism, cardioembolism, non-arteriosclerotic vasculopathies, surgical treatment of internal carotid artery aneurysm, surgical clipping, and endovascular coiling of anterior choroidal artery aneurysm. Most common clinical sign of incomplete form is hemiparesis, producing septoranopia, with sparing of a strip of vision around the horizontal midline in the blind field, probably due to a lesion of the lateral cingulate body, which is likely to happen during anterior choroidal artery infarction. Next slide, please. Other usual symptoms are hemineglect in right-sided infarct or mid-aphasia as mid-language deficit that can be found in left-sided infarct. Dystonia may be produced by infarction of the medial pallidum, where it's due to the occlusion of optic tract. Another symptom may be hemianopsia. In bilateral anterior choroidal artery infarction, the most common symptom is pseudobulbar mutism that is usually described together with a less common symptom, the abulia, causing facial dysplasia, hemiparesis, hemisensory loss, and lethargy. Besides, the involvement of bilateral cingulate bodies may cause bilateral visual field effects. Ischemic lesions are detected in anterior choroidal artery areas with magnetic resonance imaging. Homogeneous patient group show ischemic lesion in similar region, but also similarities in risk factor and etiology. Identification of this lesion carries importance in terms of prognosis and directive treatment. Unfortunately, after anterior choroidal artery syndrome, almost half of the patients are dependent in their activities and daily living, and most remain so at 3 months follow-up. In fact, involving superficial territory are associated with worse prognosis.
Based on different studies, anterior cerebral artery occlusion account for 0.3 to 4.4% of all stroke cases, and ACA strokes are more common on the left side, so that the infarct involving this area are quite uncommon. The median age of patients with ACA stroke is ranged between 59 and 74% age, with a male predominance. The risk factor are similar with regard to other cardiovascular disease. The partners of arterial occlusion are different in African Americans and Asian than in white, making Asian and African American to have higher rates of intracranial arterial occlusive. Another reported mechanism by which an ACA stroke may develop is following an arterial fixation, where patients present also less comorbidities like fewer associated cardiac disease and the lower prevalence of arterial hypertension. Next slide. The most common manifestation are motor weakness and sensory loss in the lower extremity contralateral to the occlusion side. And what variation in the clinical picture depend on whether the ACA itself or any of its branch are affected. For example, in an orbital branch occlusion, the usual result is an apathetic state with some memory loss. In a medial striate artery occlusion may result in dysarthria with impairment of mandible, lips, and tongue. Callosal marginal occlusion can result in damage to the prefrontal cortex and giving abulia, lack of initiative, or in a left side infarct of the supplementary motor area that may produce mutism, because this area normally collaborate with the Broca's area in the initiation of the speech. Pericallosal occlusion may lead to infarction of the anterior part of the corpus callosus that may result in idiomotor apraxia, a neurological disorder characterized by the inability to correctly imitate hand gesture. Another disease can be the alien hand syndrome, in which one hand appears to be independent and which the patient cannot control. Other common symptoms could be urinary incontinence, emotional lability, contralateral face and arm weakness due to damage to the caudate nucleus, internal capsule, and anterior perforate substance, or damage of both the corticopontine fiber and the lower limb strip, resulting in homolateral ataxia and crural hemiparesis. Next slide. Once an acute ischemic stroke is suspected, the standard evaluation includes performing routine airways, breathing, and circulation assessment, checking the blood glucose, performing a validated stroke severity scale assessment, and examination of the head, neck for sign of trauma, infection, and meningeal irritation, and an accurate focus history regarding the time of symptom onset. Another important step is the neurological examination that includes different assessments: cranial nerve, motor, sensory, and cerebral function, gait, language, and mental status. In order to know the type and characteristic of the stroke, it's important to perform brain imaging. And to know better the cardiovascular cause of stroke could be useful examination of the ocular fundi, checking for emboli, hemorrhagia, or the peripheral vasculature, so palpating carotid, radial, or femoral pulses. Next slide. In hospital mortality or ACA stroke, patient can range between 0 and 7.8%, but patients with major neurological deficit have a high risk of poor outcome. Conservative treatment leads to a favorable outcome in more than 17% of the patient, and endovascular treatment of secondary vascular complication is the primary therapy. The optimization of risk factor is essential for secondary prevention of stroke in order to improve outcome from the principal event.
So the middle cerebral artery occlusion, it is very clinically relevant because it supplies a wide area of the cortex. It is the most common site of ischemic strokes, and it is more common in women compared to men, with a 20.5% ratio in relation to a 15% relation to men. In the image, we see the MCA and how it branches through the cerebellum, through the cortex, supplying a very wide area. And in the upper image, the green area correlates to the lateral striate arteries. The lateral striate arteries are a branch of the MCA and also the ACA. However, with the MCA having such a high rate of ischemic stroke, it is very clinically relevant because those are structures that go to the basal ganglia. So the MCA strokes result in contralateral motor and sensory symptoms. So if you have an infarct on the left MCA territory, you will have symptoms that go to the right side of the body. The arm is affected more than the legs, and this is due to the distribution of the homunculus. The face is also affected, and the patient suffers from spastic upper motor neuron paralysis. A classical sign is a lower facial droop, and this is due to the fact that the facial motor nucleus in the pons supplies separately the upper portion of the face and the lower portion of the face. But the upper portion of the face has dual innervation from both sides of the cortex. So if you lose one side, it will still be innervated by the opposite side on the upper portion of the face. The lower portion of the face, however, only supplies by 1/2 of the cortex. So damage to 1% of the cortex will cause you to get a spastic upper motor neuron paralysis on the lower face only. These fibers that innervate the lower portion originate from the contralateral motor cortex and run in the corticobulbar tract. The left hemisphere is dominant with regard to language and logical processing, while the right hemisphere handles spatial perception. If the lesion occurs on the left side of the brain, then the patient develops aphasia. If the patient gets lesion on the right side, then they get symptoms of hemi-neglect, and this is where they can recognize objects that are presented to them visually. So that was like general overview of the middle cerebral artery occlusions. This is more in details to what happens with each one of the branches of the MCA. So we see the origin that has the stem, the upper division, and the lower division. So starting with the stem, we have the frontobasal branch that goes to the alveolar surface of the frontal lobe, and the prefrontal syndrome is the expected deficit from an occlusion here. So prefrontal syndrome will include behavioral problems. Anterior temporal goes to the anterior temporal cortex, and this will result in semantic memory deficits. Upper division has the prefrontal branch that goes to the prefrontal cortex that will result in mental disorders. Precentral goes to premotor areas that will result in Broca's aphasias on the left side and monotone speech on the right side. Central goes to the pre and post central gyri, and this results in contralateral loss of motor and sensory functions of the face and the arm. The post-central goes to the post-central and anterior parietal cortex, and the parietal goes to the posterior and parietal cortex, and both of these will result in contralateral hemi-neglect. And this is where the contralateral eye on the visual field, half of the eye is unable to make up the little details. On the lower division, we have the middle temporal. So the middle temporal goes to the middle temporal cortex and the temporoccipital to the temporoccipital area. This both results in Wernicke's aphasia, and this is unable to comprehend speech. And lastly, the angular that goes to the angular and neighboring gyri that will result in contralateral homonymous hemianopia. This is where the opposite, in the opposite eye, we have half of the visual field affected. Lacunar infarcts and hemorrhage of the MCA. So lacunar infarcts are small infarcts in the deep cerebral white matter, basal ganglia or pons, and are presumed to result from an occlusion of a single small perforating artery supplying the subcortical areas of the brain. In comparison to a hemorrhage, which is when the brain interferes function because of bleeding. Hemorrhage tends to be fast onset, and the lacunar infarcts tend to be a slower onset. Lacunar infarcts will result in pure motor hemiparesis in corona radiata and internal capsule, pure sensory syndrome in ventral posterior nucleus of the thalamus, and dysarthria. And dysarthria is a combination of a speech impediment that is also accompanied by a clumsy hand syndrome, and this is due to the genu of the internal capsule being affected. A hemorrhage affects mostly the lateral striate branch of the origin of the MCA. That is that green area that I explained in a couple slides earlier that covers the basal ganglia. Results often in ambulatory spastic hemiparesis and hemipaesthesia, so loss of motor and sensory on the contralateral side of the body, and could be fatal due to possibly lateral ventricle rupture. So the prognosis of the middle cerebral artery occlusion in a study conducted on 78 patients with a median age of 44, it was found that 5% mortality rate 94% probability to survive after 1 year, 84% to survive after 3, 78% after 5 years, 72% became fully independent in active daily living, 27% required assistance, 1% was totally disabled, 43% returned to work. Left-sided occlusion, which tends to be the dominant side on most people, was more common in those who died, as in comparison to right-side occlusion, who required assistance in daily living. So now I'm going to pass to Gideon to continue with the internal carotid artery.
Thank you, Eduardo. So for the internal carotid artery occlusion, we understand that the lumen of the internal carotid artery may become progressively obstructed by the affetmatous deposits. Common sites of the obstruction are the point of commonness into the neck, the cavernous sinus, and a slowly progressive obstruction may be compensated for by the opposite internal carotid artery through the circuit of Willis. Additional blood may also be provided through the orbit from the facial artery. At the other extreme, sudden occlusion may cause death from infraction of the entire anterior and middle cerebral territories, and sometimes the posterior cerebral artery also. So basically what we're seeing is that an occlusion to this region will normally lead to a decrease in blood flow via the ICA, which will bring reduced function to the frontal lobes to some degree, because that's where the blood function, the blood supply goes. So usually the main sign of an occlusion to the ICA is disruption to the ophthalmic artery, which is the branch of the ICA, causing visual impairment or even total blindness, usually some type of fogginess in one eye. There are also cases, you can go to the next slide. The ICA is kind of hard to notice, so there are certain cases which come out which are good to know, so they're not mistaken for others. So there are cases in which subjects rise from laying or sitting can cause noticeable reduction in cerebral functions, which indicates an occlusion to that artery. There's also a rare condition in which the patient will complain of involuntary limb movement to one or the other side. This is usually misdiagnosed as small seizures, but actually has to do with the blood flow obstruction to the frontal lobe, which, as we know, are in charge with voluntary body movements. Other signs, such as headaches or even dementia, are sometimes noticed, but these are on a smaller number of cases. So ICA can be hard to recognize. Usually a unilateral occlusion are almost impossible to diagnose due to a compensatory system that circulates the blood via the contralateral direction of the ICA. So it's basically a round circulation that can feed from either way. Both the anterior and the medial cerebral artery supply chain can be affected as well. Differentiating the ICA stroke and MCA stroke can only be done if there is a history of vision loss to one eye or the other. So without a history, it will be very hard to know, as well as with a family history telling you what happened at the exact time of this occasion. So basically, to wrap this all up, we know that the event involving an ICA will be hard to detect, if not impossible, and even diagnosing after the fact will be very hard. Only a few key signs can confirm this, the best of which will be actual imagery you can see in the next slide, which you can see in an exact occlusion to this area. We hope that you have learned something from our presentation today and that was enjoyable. Free for you to ask any questions, and we look forward to seeing you again. Thank you very much.